Hello everyone, welcome to the penultimate lecture on overview and integration of cellular metabolism. We are in class number 59 and today we will be covering energy metabolism, nutritional disorders, protein energy malnutrition, dietary fibers. So, these are the concepts that you can expect from today's class. We will be discussing nutritional indices, we will be discussing the various food items and their role, we will be discussing about dietary fibers, glycemic index, nitrogen balance and various nutritional indices regarding to nitrogen balance, and how to formulate a diet as well as many nutritional disorders. Now, I would like to say that this slide has got a lot of content that is covered. Okay. However, as you know, many different types of audience are consuming content via LPTL platform. So, the factual information contained in this slide will cater to a lot of audience, especially nutritionists and dietitians. All right. However, I will orate my slide keeping competitive examinees in mind. So, maybe I'll be breezing through few contents, but you are free to pause the slide, note whatever information is available, because anything and everything might appear important in your clinical practice. All right, but I will be highlighting every aspect that can come as a potential question. So, to start with, our first area of discussion will be nutritional indices, and the very first nutritional index that we will be discussing is calorific value. Now, you all know the definition of calorie, that is the amount of heat required to raise the temperature of 1 gram of water by 1 degree, that we have already read in our physics classes, right. And for medical purposes, we represent this value in kilocalorie because so much of calories are involved. So, how do we determine the calorific value of any ingredient? It is by completely oxidizing that said ingredient in a bomb calorimeter. This is an MCQ, how do you measure calorific value? And similarly, nutrient will also be oxidized in presence of oxygen and it will be burnt, completely oxidized in a bomb calorimeter, and thus the calorific value, which is also known as energy density, for that nutrient can be achieved. Well, this is the standard value, and there is a difference between what exactly the calorific value is obtained experimentally, that is in vitro, and it is in vivo. All right, this is what we get in our body. And you know, multiple food items have got multiple calorific value. I mean, many food items have got their characteristic calorific value. It is not possible to memorize each and everything, right. So, luckily in today's date we can simply browse. There are multiple websites that are available that will give you a specific food item with respect to your specific region. For example, in India something is available Bengal gram, it may not be available in Africa, there fava beans are available, for example. So, you can check each and every item's calorific value because it will be very important when you formulate diet. So, all these principles will be required in later part of our discussion. Next index, respiratory quotient. How you can define? It is a quotient, means it is a ratio of what? Carbon dioxide eliminated to oxygen consumed. All right. It is a dimensionless coefficient because since both carbon dioxide produced and utilized are in liters per gram, they mutually cross out each other. So, different nutrients have got different respiratory quotient or RQ. For example, carbohydrates have got an RQ of 1. What does it mean? It means it indicates that each gram of oxygen consumed, 1 gram of carbon dioxide is produced, all right, for a unit of carbohydrate. Similarly, fats have got 0.7 and proteins have got 0.8. However, as you know, in our diet everything is mixed up. So, an ideal balanced diet, the respiratory quotient is 0.8. It is actually 0.82 to 0.85, but for exam purpose, if the values are very close, 0.6, 0.7, 0.8, 0.9, the answer will be 0.8. You need to know something, that whenever fat utilization increases, RQ decreases. So, fat component when it is more in diet, when its utilization is more, RQ will be less. This is observed in diabetes mellitus because carbohydrate consumption is hampered. Without insulin, carbohydrate cannot be consumed. There is excess carbohydrate in blood, I mean glucose in blood, but it cannot be consumed. There ketolysis happens, all right, ketone bodies are utilized, and that is when the RQ is actually the lowest. So, RQ is lowest during ketolysis, it is low in diabetic patients compared to normal individuals. One important trivia or quiz or MCQ, whatever you need to, you can say, is oxygen consumption is measured by Benedict Roth apparatus. This is the Benedict Roth apparatus. This is how it looks like. It's an illustration. So, you should remember these points with respect to RQ. Next, BMR, basal metabolic rate. You might be knowing what is BMR, in that case you can very well skip to the next slide, but here I will be telling you few very important information that you need to know regarding definition. It is the energy expended or spent or required by the body of an awake individual, very important, one needs to be awake during rest. What kind of rest? Physical, emotional, digestive rest, alright, to maintain what? Basic physiological function such as respiration, circulation and cell production. I am sitting just like that, very lazy, I am very close to BMR, alright. Whenever I am doing something, it is more, BMR is the energy expenditure is exceeded than BMR, okay, and whenever I have fallen asleep, it is reduced, okay. So, how can we measure BMR? There are multiple methods, among them indirect calorimetry is the best method, it is the most accurate method, okay. There are multiple methods, for example, bioelectrical impedance, DEXA, dual energy absorptiometry, even body temperature can give us some idea about BMR, but that is less accurate. The most accurate, it is indirect calorimetry, and the original equation, that is Harris-Benedict equation, is actually historical, it is what we mostly relate in textbooks. It is the equation which defined BMR in the first place, but later it has been modified. There are more accurate predictive equations now which can predict the basal metabolic rate based on our weight and height, okay. Next, what are the factors affecting basal metabolic rate? These are all the factors that can affect basal metabolic rate. Age, it is very high during active growth, when growth stops, BMR reduces, okay. Sex, males have more BMR. Temperature, BMR is high in cold, much of the energy is spent to thrive against the chilling environment, okay. Exercise increase and fever both increases BMR, and hormonal status, okay. If there is an hormonal imbalance, that also affects BMR. For example, BMR becomes low in hypothyroidism and Addison's disease. There are multiple other disorders, but these two are the most important. Similarly, BMR becomes high in hyperthyroidism, pheochromocytoma, all these conditions that lead to hyperdynamic circulation, alright. Next index that we need to know is SDA, specific dynamic action, also termed as thermic effect of food or diet induced thermogenesis, DET. So, from these names it is very evident what does it mean. It means the energy expenditure beyond the BMR, above the basal metabolic rate due to consumption of food. So, why do we need excess energy when we consume food? Basically to digest, to absorb, to transport and store the food material, alright. Here is a schematic diagram where you can see lipids actually increases the heat or increases the energy expenditure very low compared to, very less compared to carbohydrates and proteins. Proteins have got the maximum SDA, alright. So, these things have to be kept in mind. The SDA, that is energy expenditure due to for digestion, has also to be kept in mind for micro adjustment of calorie whenever we are prescribing diet. Again, we will keep that in mind. This point should be kept in mind when we are formulating diet in a later parts of our discussion. So, that was all about nutritional index. Next we come to important nutritional ingredient. So, what is the first most important ingredient? Carbohydrate, alright. Why carbohydrate? We know a lot of carbohydrate, we have discussed chemistry, we have discussed the metabolism, integration in detail. Main thing you need to know, carbohydrate should consist of about 60 to 65% of the total calorie. It should contribute to that much calorie among the total diet, okay. That is known, you must have read this in your school lessons, alright. Majority of the diet consists of carbohydrate, approximately 60 to 65. What we need to know now, after you have prior to you completing this course, is carbohydrates also contribute to dietary fiber. We are here to focus the role of dietary fibers in metabolism, alright. So, what are dietary fiber? They are actually indigestible carbohydrate, okay. Indigestible carbohydrate are called dietary fiber. The indigestible components of carbohydrate are called dietary fibers. What do they help in? They actually help in increasing the normal motility of GIT, okay. There are multiple factors we will be discussing again. So, it is due to the dietary fiber which is actually beneficial to us, and western diets, that have got less dietary fibers have got higher incidence of diseases like colon cancer compared to Indians. Indian diet an average Indian diet has got a lot of vegetables and fibers. That is why the incidence of colon cancer is less compared to Western countries. Okay, so how does dietary fiber help us? Number one, they maintain a healthy digestive system by increasing the bulk of stool. Mind it, soluble dietary fibers, they increase, they absorb water due to osmotic effect, and they help in regularizing bowel movement and prevent constipation. Very important, first and very most important point. Next, what it does, due to an increasing volume, okay, it leads to a feeling of fullness, and due to that it helps in controlling appetite. We don't feel like eating again soon if a previous diet has got a more heavy dietary fiber content, okay, and thus it prevents overweight, okay, weight management. Those who are planning to reduce weight systematically should include a lot of dietary fiber in their diet, okay. It can help in reducing calorie intake. Next, manages glucose levels. Because of the same thing, number one, it is preventing excess consumption of food, right. Next, it also slows down absorption of glucose. So, due to both of these factors, the first and the second factor, it is actually helping diabetes patients. So, diabetic diet should have a lot of fiber content, all right. Not only patient of diabetics, those who are pre-diabetic, those who are at risk, even dietary fibers can help them as a essential part in their diet. Next, what they do, they help in reducing, research studies have shown that dietary fibers reduce LDL. LDL, you know, it is also termed as harmful or bad cholesterol because it leads to impairment of cardiovascular health. So, cardiovascular health is improved when there is an excess or adequate amount of fiber in diet, all right. Nothing in excess is good, adequate is essential, low is harmful. Next, gut microbiota. Gut microbiota is a branch in its own. Now, it has been shown that gut microbiome contributes to effective functioning of all organ system. So, a healthy gut microbiota, if it is maintained, it will help in improving immune function, better nutrient absorption. How does dietary fiber help that? It helps as a prebiotic, it is a food for intestinal bacteria, all right. So, keeping all these points in mind it, if you suddenly want to include, yesterday you were not including dietary fibers, now after attending today's class you are conscious and now you are increasing dietary fiber, you should increase that gradually, all right. Not all of a sudden you are increasing a hell lot of dietary fibers, it will be problematic. So, you can take the help of professional dietitian to consult them to gradually increase dietary fibers, increase the amount of soluble dietary fibers, soluble indigestible carbohydrates in your diet. Also, drink plenty of water along with that for your digestive comfort, okay. So, here is a chart, this is the actual schematic representation of a dietary fiber. They are long chains of insoluble carbohydrates, okay. Our body does not have the required enzymes to break them. So, cellulose, hemicellulose, lignin, pectin, this is showing their chemical nature and what are their physiological effects in, if you can, if you are including some of them, that actually contributes to one or all of those features that I already just mentioned, all right. So, you can memorize them for MCQ purpose, but mind it, the functions of all of them are more or less close to each other. So, this is how dietary fiber is actually affecting the metabolism. So, you can see what it is doing. Number one, it is increasing intraluminal viscosity, it is reducing gastric emptying, all right. Macronutrient absorption, I told you it is slowing down absorption. So, postprandial glycemia, the immediate rise of glucose after food is reduced, okay. So, it decreases insulin secretion, insulin sensitivity is increased, mind it, okay. How insulin sensitivity is increased? It is actually, the dietary fibers can be fermented into short chain fatty acids, okay, and that actually decreases hepatic glucose production and free fatty acid breakdown, okay. We do not need gluconeogenesis in that way. Thus, insulin sensitivity is increased, but insulin secretion is decreased. Not only that, there are intrinsic effects of dietary fibers which are actually decreasing the energy palatability by increasing the chewing and mastication. So, what it leads to? It leads to a satiation, early satiety, you feel like full even if you are not full. So, by decreasing the energy intake, it actually promotes fat oxidation and decreases fat storage, right. So, post absorptive hypoglycemia is also decreased because insulin secretion is decreased. So, all of these factors ultimately is contributing to a decreased body weight. Okay. So, a big if you get a long question on effect of dietary fibers on energy metabolism, you can memorize and quote this diagram. If you miss out 1 or 2 points, it is not that much penalizable, but just make sure your fundamental concepts are right. Okay. Next, a very important part of carbohydrates in diet is glycemic index. We must know glycemic index if we are planning to prepare a good diet. So, what is glycemic index? You already know. Glucose tolerance. Glucose tolerance means when we prescribe or when we inject or feed glucose to any individual, there is a rise of glucose, I mean with time. It goes up on the first hour, it comes down in the second hour, and then it goes back to normal third hour or beyond, right. So, a glycemic index of any food or any carbohydrate is tested by comparing this area under curve or this glucose tolerance curve of 50 gram of that carbohydrate compared to what 50 gram of glucose we will have done as a reference food. Okay. So, this is the glycemic index curve. You can see the food with high glycemic index. So, what are the foods with high glycemic index? That actually breaks down very quickly, provides a lot of glucose and readily available sugar. For example, all your favorite fast food, french fries and processed foods, canned beverages, all those things, okay, very high glycemic index. Compared to that, what are the foods with medium glycemic index? Those break down slowly, not that much faster compared to food with high glycemic index. Our whole grain, roti, chapati, bread are example of medium glycemic index food, and fruits are very good example of low glycemic index food. Okay, they take a long time to break and deliver the glucose to the bloodstream. So, if this is the curve comparing 0 hour, 1 hour and 2 hour, the rise and fall of glucose is very steep in foods with high glycemic index, and that is harmful. Food with lower glycemic index are always preferred. Okay. So, area under curve of food of interest divided by area under curve of glucose, 50 gram of each multiplied by 100 is the glycemic index, again dimensionless. So, we can also get idea about glycemic index of many foods from these websites. Okay, there are multiple websites that are available. I have quoted one from Harvard University and one from Commonwealth Foods. Okay, I mean very well health.com. Okay, you don't need to do much. Okay, in your search engine you can just type glycemic index of foods and all these websites will prop up. Okay, these are peer reviewed websites, the information are pretty accurate. You are free to check in what foods are you consuming and what is the total glycemic index you had today till you are attending this class. Okay, very interesting. Let us go ahead. We now move on to lipids in diet. Lipids in diet, lipids actually give us a concentrated source of energy. Why do we need lipid? It is essential to absorb or for metabolism of all the fat soluble vitamins and essential fatty acids that are required by the body, they needs to be met. Okay. 10% of the calories or 20 gram per day should be provided by lipid. That volume in that amount increases during pregnancy and lactation. So, special conditions we need to keep in mind when formulating a diet. Okay. Visible fat actually means the fat that you know that these are fat, lipid, oil, butter, margarine, etc., that you are eating, cheese, those do contain fats and lipids, okay, oils. What is invisible fat? That is fat that is present in other ingredients that you may not be aware of. The fat that is present in egg, fish, meat, cereal, nut, oilseed, whatever food you are consuming, they will have some amount of fat. For example, cereal have got 1 gram of fat per 100 gram. So, if you are meticulously monitoring the amount of fat that you are taking, these things should be considered. Luckily, nowadays there are multiple applications or apps that actually will break down the total amount of nutritional ingredient that you consume. You just need to incorporate the name of the food item and all the subsequent items will be broken down and will be shown, right. So, one thing we need to know, that is trans fatty acid. What is trans fatty acid? you know cis double bond and trans double bond. When the double H bond is present on the single side, it is cis. When it is present on both sides, it is known as trans, H on the double bond, right, on the both side of the double bond. So, trans fatty acid are actually harmful. Why? They aggravate insulin resistance, they adversely affect the endothelial function. Why? When trans fatty acid is produced, it is produced when edible oils are hydrogenated. Why edible oils are hydrogenated? To increase their shelf life, to prevent any rancidity. Processed dairy product, for example, margarine has got high trans fatty acid. Okay, they lower HDL, then they elevate LDL. So, harmful in all way. All right. Mind it, saturated fatty acid, saturated fat raise serum cholesterol, while unsaturated fat lowers it. So, we actually prefer unsaturated fatty acid in diet. Polyunsaturated fatty acid, that is PUFA, are preferred. But as I told you earlier, nothing in excess is good, right. So, the ideal content lipid should be about 15 to 20% of the total calorie that I told you, sometimes 10 to 15 depends on the diet formulation, and among them 20 to 30% may be polyunsaturated fatty acid. Why only this? Why not more? Because excess polyunsaturated fatty acid, PUFA, is actually injurious. They have a chance to produce free radical. There is a phenomenon that is known as lipid peroxidation, by which excess free radicals may be produced and they may lead to damage. Okay, ROS, reactive oxygen species, I have discussed many times. This term will be excess if excess PUFA is in diet. Ideally, the ratio of saturated fatty acid to monounsaturated fatty acid to PUFA should be 1:1:1. Also, you need to monitor the cholesterol intake, which should be less than 250 mg per day, right. That was all about lipid. We move on to protein. So, proteins are essential building blocks, right. We have studied essential amino acid means amino acid which needs to be mandatorily provided from outside. So, we need some protein in diet, all right. How much? 10 to 15% of the total energy is derived from protein, okay, and we need to keep that in mind. However, when adequate carbohydrate is present in diet, the amino acids that are available, that are produced by breaking down of protein, are not utilized to form energy. They are utilized to either synthesize proteins or to synthesize other non-essential amino acids. Okay. So, this is known as protein sparing effect of carbohydrate. If you have got more carbohydrate, you can spare some protein in diet. However, during starvation, amino acid may act as energy sources, that have already been discussed, because starvation metabolism has been discussed in detail. So, this is a chart showing recommended protein allowance among various age group and special cases. So, there is a case for children up to 10 years, adolescent boys, adolescent girls, adult, pregnancy, lactation. These values you need to memorize for multiple choice question purposes, and this also might vary from country to country and even state to state, or even hospital to hospital, institute to institute, based on your diet formulary. So, be mindful, you can stick to one standard, WHO standard, and quote that as a reference when you are answering in exams. Okay. So, regarding the protein intake, as per WHO, it is 0.7 to 0.75 to 0.8 gram per kg body weight per day. Okay. Why it is required? For synthesis of all the essential amino acids that should be supplied. Okay. Okay. Essential amino acids should be supplied in diet. For that, we need protein, because proteins will be broken down, the components, the essential amino acid will be broken down by proteolytic enzymes, and from them non-essential amino acid will be synthesized. In reality, only 3 amino acids are dispensable, means even if there is no protein in diet, alanine, aspartate and glutamate can be synthesized from pyruvate, oxaloacetate and alpha ketoglutarate. So, these are the direct products of transamination of these 3 very important intermediates of carbohydrate metabolism. For synthesis of all other non-essential amino acid, we need some or the other essential amino acid, alright. So, even if those amino acids are semi-essential or non-essential, some form of protein needs to be provided in diet in order to synthesize them from some or the other source. Okay. However, these precursors are available in plenty. So, Now, let us talk about nitrogen balance, right. So, nitrogen balance deals about protein. You know, nitrogen, the main source of nitrogens are proteins, the amino acid, the amino component of nitrogen. So, we need to eat protein in order to tackle the loss of protein. So, what is nitrogen? Obligatory nitrogen loss means the loss we cannot control, loss in feces, loss in urine, loss via skin, approximately equivalent to 22 gram of protein. Also, some amount of protein is required for synthesis of other protein, that is known as protein turnover, and that is actually very high in case of active growth. So, adolescent, pregnancy, lactation, convalescence, that is healing from any illness, nitrogen requirement is very high, or nitrogen use is very high, therefore, nitrogen requirement should be very high. They should be supplemented with excess protein and nitrogen. However, as growth stops, protein requirement also decreases. So, this is the nitrogen balance equation. Intake should be equal to urine plus feces plus stool, I mean skin, alright. The loss through those should be equated with the intake. When those are the same, body is supposed to be in optimal nitrogen balance. When nitrogen balance, the excretion exceeds, body is in negative nitrogen balance. When excretion is less, when the intake is more, body is said to be in positive nitrogen balance. Okay. So, what are the factors that affect nitrogen balance? Growth, you see all these factors, growth, hormonal influence, pregnancy or healing, as I told you, whenever there is an active growth, synthesis, anabolism in body, there will be positive nitrogen balance. So, nitrogen balance will be more or positive in this case. Hormones, of course, certain hormones affect either way. So, for example, corticosteroid can cause a negative nitrogen balance, whereas hormones, anabolic hormones like growth hormone, insulin, androgen, they promote positive nitrogen balance. And conditions that are debilitating, that are leading to weight loss, acute illness, chronic illness, protein deficiency, all those cases are leading to negative nitrogen balance. So, we need to be very mindful. So, how can we calculate the nutritional value of protein? It is very easy actually. If you think in a way, we can give protein as the only source of nitrogen to an animal and then calculate the weight gain. It can be done in experimental animals. Okay. So, there are multiple essential nitrogen indices that should be learned. Okay. So, we will be discussing 4 of them: biological value, NPU, that is net protein utilization, chemical score of protein, and digestibility coefficient of protein. The first two, biological value, definition, retained nitrogen by absorbed nitrogen into 100. All of these are dimensionless. So, how do we calculate retained nitrogen? Nitrogen intake minus nitrogen output, very easy. And what is nitrogen output? Urine plus fecal. And how we can calculate absorbed nitrogen? Nitrogen intake minus nitrogen that is excreted in feces. Okay. Next, NPU, net protein utilization, very easy, retained by intake, the amount of nitrogen that is retained to the ratio of amount of nitrogen that is taken multiplied by 100, that is NPU. Next, we should know about the concept of limiting amino acids. You know, certain amino acids are deficient in one or more, certain proteins are deficient in one or more amino acid. Okay. And if that particular protein is fed to an experimental animal, it will fail to grow, and that amino acid that is actually causing the limitation is known as limiting amino acid. Okay. This is the concept of limiting amino acid. We study the weight gain when feeding that only amino acid to the experimental animal. So, how can you overcome that? We can overcome that easily by a thing that is known as mutual complementation or supplementation of amino acid. We will select a protein which has got an amino acid that may not be present in other amino acids. We can combine. For example, cereals are deficient in lysine but rich in methionine. Okay. On the other hand, pulses are deficient in methionine but rich in lysine. So, we can combine them. So, common Indian diet, rice and dal, chapati and dal, when they are combined, we can see they are behaving equally to a top class protein. So, the proteins which actually promote growth, good growth, that are known as first class protein, where proteins that are limiting are known as second class protein. They do not have all the essential amino acids. So, when we can combine two second class protein, their behavior act as the first class protein. So, this is a protein which has got all the essential amino acid. Okay. So, thus supplementation of protein may be seen in weight gain, that has led to weight gain in animals, thus proving the phenomena of complementary supplementation of medicine. Next, we see there is a list. Okay. These are the limiting amino acid in this, these are the food items, and the list says what amino acids are limiting and what amino acids can, what foods can actually complement them if they are the sole source of component in diet. Next two scores that we are discussing, chemical score of protein. So, how do we detect the chemical score? Milligram of limiting amino acid in 1 gram of test protein by milligram of the same amino acid in 1 gram of egg albumin multiplied by 100, right. Next, digestibility coefficient of protein, nitrogen absorbed by total nitrogen of the protein, all right. So, how do we calculate total nitrogen absorbed? Again, total nitrogen in the protein by nitrogen excreted in the feces. Okay. So, these indices are confusing if we just learn them one after another. So, it is extremely important you write them, you practice them over and over again, that way you can be very clear. Next part of our discussion will involve formulation and prescription of diet. Okay. So, number one rule, see these rules can vary again from institute to institute, but more or less the general principles are same. Okay. So, what are the general rules? First, the diet should be balanced. So, what are the principles, general principle? Number one, individually tailored. Okay, it should not be same for everyone. Whenever you are prescribing a diet, it has to have a variation. It should be realistic and sustainable. You cannot give some item that may not be, that may sound very good on day one, but on long term someone will give it up. So, it has to be realistic and sustainable. It has to be well balanced. The ingredients need to be well planned. We need to focus on the amount of carbohydrate to protein to fat. It should be simple and locally available, palatable. We should also consider limiting amino acid for considering essential amino acids, cereal plus protein, total calorie intake, correct and balanced energy expenditure. We should take into account the SDA. We should provide adequate amount of nutrients, macro and micronutrients, for example, iron, calcium, especially for Indian diet. These sources are limited in Indian foods, and absorption of Indian food habit hampered their absorption. So, they need to be supplemented in diet. They should include adequate roughage, that is dietary fiber, and they should have variety, not all the same should be same every day, and they should be changed regularly. So, regular monitoring and reviewed periodically should be done. Okay. This is number one general rule that should always be followed. The next thing is, should determine what is the exact amount of nutrition or the calorie or the protein and calorie that is needed by the individual. It will vary from case to case. What is our goal? So, diet should be goal oriented. If we are trying to treat an undernutrient case to gain weight, we should adjust the diet in such a way so that it has got excess 5 kilocalorie per kg body weight, that has to be adjusted till ideal weight is achieved. Similarly, in case of overweight individual, we should reduce 5 kilocalorie per kg per day. Okay, these numbers are important. And what is the ideal kilocalorie per kg per day? 30 to 35 kilocalorie per kg per day. So, we need to adjust depending on their physical activity, occupation, what they are doing, age, sex, health status, everything, right. So, these are the numbers for sedentary activity: 30% of BMR, moderate work 50%, heavy work, moderate work 40, heavy work 50. Okay. Also, pregnancy and lactation, we need to consider what excess amount of kilocalorie should be added in diet. Again, it depends from country to country, and you should consult your national guidelines for that. Also, one example, calorie depending on exercise, what is the activity, what is the work, I mean, you should take history, what they exactly do or what is their goal. So, depending on many such online charts that are available, also they are available in multiple textbooks, you can calculate the amount of extra nutrient that you need to include in order to maintain the balance or in order to adjust your weight loss or weight gain goal. All right. Next, what is the next rule? Calculate the proximate principles. Proximate principles mean the total calorie that is needed in, now that we know what activity they are doing, whether it is overweight or underweight, we now know the total amount that is needed, right. So, next we need to adjust based on the amount of carbohydrate, protein and fat. We already know what percentage should be there. Other than that, then we need to also add the minerals, trace elements, vitamins, iron and calcium, etc. Right. Any additional, if it is needed, roots and tubers can provide, all right. And we, of course, I am repeating myself over and over again, special condition, pregnancy, lactation or even diabetes should be considered when prescribing a diet, because prescription diet is always goal oriented. Next, now that we know all of this, now it is the time so that we can enlist the food items that are locally available based on their choices. One by one we calculate what are the amount of energy that is available per food item. Similar food items can be grouped together, that is known as food exchange. Someone can have roti one day and rice the next day to calculate variations. So, similar items can be grouped together, very important when prescribing or formulating a diet. And finally, when all of this is available, they should be divided into 3 meals, that is breakfast and lunch and supper. So, that actually covers all the principles that are needed for diet formulation. And finally, we move on to last phase of our lecture, that is nutritional disorders. Common nutritional disorders include all of them: obesity, starvation, protein energy malnutrition in the form of kwashiorkor and marasmus, anorexia nervosa, bulimia nervosa, vitamin deficiency disorder, trace element deficiency disorder. Mind it, whenever nutrition or some nutrient is absent in diet, there will be deficiency disorders. However, vitamins and minerals are not a part of this course, we will not be discovering them. There are other courses and future course maybe this team will bring in order to cater that area. Okay. Starvation has been discussed in detail, metabolic effects of starvation, we all went through that class together, right. Obesity also has been discussed in detail. Mind it, malnutrition is generally synonymously used as undernutrition, but obesity, that is overnutrition, is also a type of mal or bad nutrition, all right. So, that leaves us with the others. Okay. So, these are the few disorders which we will be discussing today. Number 1, bulimia nervosa, you do not need to know much, it is again a part of behavioral eating defect, okay. Psychiatric disorder, they often need professional help or therapy. What happens in bulimia nervosa is an uncontrolled habit of eating, after which the person or the individual becomes excess or conscious that they will gain weight, and they use means of purging, they use excess medication, they resort to vomiting. Very dangerous eating disorder, it leads to many dreaded consequences in symptoms and signs. They should be easily treated and they lead to depression, anxiety. So, mental health is jeopardized. So, in bulimia nervosa, the person is eating more, a contrasting situation, but yet psychiatric disorder is anorexia nervosa, where there is a distorted perception of body. It is a very beautiful illustration that a lean and thin person perceives himself or herself as a, it is mainly common in female population, but it can happen in males, is they think they are overweight and they resort to extreme dietary habit, they resort to avoiding food items, okay, in order to maintain their health, in order to maintain the lean and thin condition. But what happens reality, they are already emaciated. This is a very serious disorder, again problem of mental health, organ damage, electrolyte imbalance, weakened immune system and so many things that need to be treated in a mental institute. Psychiatric help is required, mental health treatment is required to treat anorexia nervosa, all right. That leaves us with the last part of our discussion, that is protein energy malnutrition. This is a type very serious disorder that is common in babies, especially in developing countries, where there is it is a term that is also known as, earlier it was known as protein calorie malnutrition or PCM. There is a coincident lack of dietary protein and or energy. Why we say and or energy? Because there are subtypes. In kwashiorkor, protein malnutrition is predominant. By malnutrition we mean undernutrition, all right, very important. It is also known as protein energy undernutrition. Marasmus, specific calorie intake is deficient. And what is marasmic kwashiorkor? Both simultaneous protein and calorie are deficient. It is the most severe form of malnutrition. You know the kwashiorkor name, it actually signifies these protein energy malnutrition disorders are very common in African countries, and the term kwashiorkor has been derived from a local language Ga tribe of Ghana, which actually means the disease of the deposed child, disease of the earlier child, means the sickness when the baby gets, when a new baby is born. Why? In reality, whenever the new baby is born, all the care is taken for the new baby, and the old baby is not taken care of in such a way so that they undergo malnutrition, right. So, what are the biochemical features, the things that we are here for? Hypoalbuminemia happens in both, especially in kwashiorkor, and in value less than 2 gram per deciliter is a biochemical marker of kwashiorkor. RBP, retinol binding protein, low. Immunoglobulin high due to increased infections. Fatty liver may be present in kwashiorkor due to altered lipoprotein metabolism. Fatty liver may not be present in marasmus. Serum free fatty acids usually high, alright. Malnutrition, body is trying to utilize fats. Glucose tolerance is normal and decreased. Glucose, potassium, magnesium, hypoglycemia, hypokalemia, hypomagnesemia. In kwashiorkor, the total water content of the body increases up to 60%. So, this is the difference, compare and contrast between kwashiorkor and marasmus. Marasmus, younger babies, less than 1 year, okay, it is a very severe form in younger, but kwashiorkor I told you the older child, so 1 to 5 years. Calorie deficiency in marasmus, protein deficiency in kwashiorkor. Why it happens? Marasmus, early weaning, repeated infection. Whenever we are early feeding the baby with weaning food, their absorption is not happening properly and malnutrition. Whereas, in case of kwashiorkor, starchy diet after weaning creates a state of undercurrent malnutrition, and that is precipitated by an infection. Growth retardation is marked in case of marasmus, but not in kwashiorkor. Attitude, the child is irritable in case of marasmus and is lethargic in case of kwashiorkor. Appearance, sunken eyes are inside, okay, and appear skin and bones, you see, in case of marasmus. But in case of kwashiorkor, the child may look plump, it may actually falsely appear fat due to excess edema or water content in the body. Appetite is normal in marasmus, but anorexia, that is a feeling of not willing to eat, happens in kwashiorkor. Other clinical features, skin is dry in marasmus, and there is a mosaic pattern, that is known as pavement dermatitis, present in kwashiorkor. Hair again sparse, curly, curls may be lost in case of kwashiorkor, right. In case of marasmus, there is muscle wasting, whereas in kwashiorkor, angular stomatitis, chelosis are prominent. Muscle wasting is there, but it is hidden under the edema. Albumin, as I told you, both low in both cases, but less than 2 gram per dl is a sign of kwashiorkor. If we are cortisol level, that is increased in case of marasmus and decreased in case of cortisol level. So, finally, what is the treatment of any type of protein energy malnutrition? Supplementation with diet, alright. We need to supplement the calorie and the protein. For example, in case of India, a mixture of 3 parts of vegetable proteins, or example Bengal gram and 1 part of milk is very effective. Malnourished students tolerate fat very well. So, fat can be supplemented more and more initially to supplement, alright. How we will know that protein energy malnutrition is being treated, especially in case of kwashiorkor? Weight gain, disappearance of edema, rise in serum albumin, these are all the important markers of treatment of PEM. And lastly, what will happen if we do not treat PEM? If we do not treat PEM, those are the sequelae that will lead to permanent and irreversible impairment, both physical and functional. There will be disability, both mental and physical. So, there will be mental retardation in babies. Not only that, a history of PEM in childhood may also affect intellectual abilities in adulthood. But the good thing is, timely correction of moderate and mild cases may prevent any lifelong consequences. So, after this long class, this is the conclusion. We discussed about nutritional indices, the nutritional value of all the food ingredients, carbohydrate, protein and lipids. We discussed the role of dietary fibers, we discussed glycemic index, indices of nitrogen balance, we discussed protein energy malnutrition, other nutritional disorders like anorexia and bulimia nervosa. These are my references for today's class, and I thank you all for your patient hearing. This was the 59th class. This is the last time you are seeing me in this lecture session. It was a wonderful journey to learn together, to teach you all, and of course, we will be seeing each other again in the live session. I thank you and we will see you there. Bye.